Okay, so guys, welcome to part 2 of our neonatal infections. So in this video we're going to talk about makes the what makes neonates to be uh, to be at risk of this infection. So they're at risk because neonates are relatively immunosuppressed. Immunosuppressed because they have immature or underdeveloped immune system components. Like they've got immature neutrophils, they've got immature complement system, they've got so because neutrophils are immature, they cannot perform that function just like immature macrophages. Let me say macrophages. They cannot perform that phagocytosis function, and even that chemotactic function. So they cannot respond to pathogens as the rest of us can. So they also have an immature or underdeveloped skin barrier. Let me just say poor skin. Remember, the skin is part of the immune system, the innate immune system. So this is why. So now, how do these infections present? Clinical presentation. So this is one of the reasons why it's difficult to deal with neonates and just say children in general, because whenever they are sick, they cannot verbalize and their symptoms are almost always non-specific. So they can present with vomiting, they can present with poor feeding, they can present with, they'll just be crying, inconsolable. And now you have to be the detective and look for the reason why they are crying. Just general change in behavior. Mother will just tell you this child is not him or herself. Yeah, they will just be sick looking. They might have a rash. They might have some red eyes with some pus. They might have have some skin infection, like obvious, maybe an abscess or cellulitis, whatever. And then they might have hypoglycemia. They might have hypoglycemia. They might have hyperglycemia. They might have fever. They might have maybe hypothermia. So they might even have metabolic acidosis in terms of the investigations now. So these are the things that the mother can complain about, or the nursing staff. These are things that you can do. Metabolic acidosis, don't even know where it's coming from. And then, so depending where the infection is sometimes, so they might also have increased respiratory rate, which is tachypnea. They might be tachycardic. Etc. So let's just clear space so that we can continue. So let me just put this. They might have jaundice. They might have abdominal distension or even abdominal pain. Yeah. Okay guys, so we did look at the general causes or the general pathogens that causes neonatal infections, late onset and early onset. Now let's look at specific infections. Before that, let's just do what is a workup for them, like investigations. So when they talk about a septic workup, so because that's what you're gonna do, we're gonna do a septic workup. So whenever the consultant or the senior talks about a septic workup, this is what they are talking about. Sometimes they will tell you what septic workup is. Sometimes they won't tell you. They'll just say, do a septic workup. But always, if you're not sure, you can just ask. But yeah. So a septic workup, you do your bloods. So you're gonna do FBC there, LFTs, you're gonna do UNEs. Obviously, what you wanna check is, you're gonna look at the entire FBC, but you want to check the white cell count there. Remember, leukocytosis and leukopenia show infection. They're a sign of infection. So when you see leukopenia, never say the child doesn't have infection, right? There isn't much there, but you can, it's always a surprise that you can just find something that is wrong when it comes to the UNEs. But if the child is behind with fluids, maybe they've got some fever, now they are behind with fluids, or the infection is causing AKI, that's where you're gonna pick it up. So this is not really to screen for the infection, but to look at the hydration status and also the involvement of the kidneys of the neonate. NFTs, some will come with jaundice, so you want to look at that, what's happening there. And also if they're maybe getting into some organ involvement, if they've been having sepsis for a long time, they were brought home from home very late, so you can see if how the extent of the liver involvement, right? So you're gonna do that. Then you're gonna do the CRP. CRP, seroactive protein, is not a sign of infection but inflammation. What is it's used for is just to check the trend, how effective antibiotics are. If you've got a child who's got a CRP of 50 and then you give them antibiotics and then after 2 days you check it, now it's 25, so you know that you are winning. But if instead of being 50, now the next time you check it it's 200, you know that you're losing the battle there. So it's just a tool to monitor, not really to diagnose infection. Because even, whatever inflammatory condition you might have, CRP will be high. Another one that is a gold standard is a blood culture. Blood culture, very, very important. Because as much as we said that the causes of sepsis for early onset is like group B, Streptococcus, E. coli, there are other bacteria that can cause it. Even the same applies with late onset. We have mentioned them: Staph, E. coli, Klebsiella, Pseudomonas, but there are other bacteria that can still cause. So you want to know which one is the actual culprit so that you can de-escalate with your antibiotics. You don't want to keep someone on broad-spectrum antibiotics forever, you see. So you want to identify the culprit. So you want that blood culture. And the blood culture is 2 bottles, right? It's the aerobic and the anaerobic. And you want at least 0.5 mils in both bottles, and try to be as sterile as possible, because you don't want skin commensals to be in your results. So you do urine. So here you are screening for UTI. They will teach you the ways you can take urine, because you don't want urine to be contaminated. You don't use urine that is in the catheter. You don't use that urine. You want to catch a clear stream or aspirate in the suprapubic, or make sure that the perineum is very clean before you can take. So just check for UTI there. So this is what the septic workup is, né? And then you do a chest x-ray, check for lung involvement, and then also you do a lumbar puncture, check for meningitis there. So this one, checking for pneumonia, meningitis, septic workup. Yeah, these are things that we do for septic workup, because you want to find the actual pathogen that is causing the infection. Let us look at specific infections. Né? Let's say meningitis, group B, strep, group B strep, E. coli, skin, strep, staph, UTI, E. coli, what else? Intravenous catheters. Intravenous catheters, coagulase negative stuff, and we also have Staph aureus, Enterococcus, gram-negative. So this is it guides your broad spectrum antibiotics according to the type of infection that you think you have. But at the end of the day, you need to do the send specimen to the lab to know the actual cause. So for things like pneumonia, group B, and we said it's strep A-Galactea. So there are many others, guys. There are many others. Strep group A here. Group A Streptococcus. And the Staph aureus. Yeah, so there are many others. So NEC, E. coli, NEC is E. coli, Strep C, L, Clostridium. Need to sleep, guys. Clostridium species. Yeah, so these are the most common neonatal infections. These are the most common pathogens. So what we need to do, in another video we're going to talk about the antibiotics. Okay, so what are the antibiotics that are used? So the antibiotics are not so many. Yeah, there will be some slight differences, but from place to place. But most commonly, they are put on ampicillin, plus aminoglycoside, gentamicin, or amikacin, right? So it's a combination of this and one of these. And in some places they say you can even put, if there's a problem, let's say maybe you encounter some side effects there, you can put them on one of the, I think it's 4th generation cephalosporins. I think I need to be very careful here. I'll check, I think Cefixim. I'll put a comment just to confirm this. There are like 3 others that you can put, but not ceftriaxone. And then now depending, these are like your first line. Then if there are indications, you can go to meropenem, like a second line, vancomycin, obviously you also look at your seniors will tell you, and also look at the literature. But the first line antibiotics is usually ampicillin and amikacin, or ampicillin and gentamicin. And then depending on what you find, then you can now change to meropenem, vancomycin. But these are the common antibiotics that they use there. And yeah, I think that's it with the neonatal infections. I think we have covered everything now. Thank you. I hope that it helps.